Looking for a professional office space that makes it easy to focus on growing your business? At J. Kenba Executive Suites, we offer turnkey office solutions with stylish furnishings already in place so you can walk in and get right to work. Our leases include access to Wi-Fi, managed building access for security, on-site parking, utilities, and regular cleaning services, giving you peace of mind and a workspace that's always clean, secure, and business-ready. Whether you're a mental health professional, insurance agent, notary, or other service-based entrepreneur, we provide the professional environment and amenities you need to impress clients and operate efficiently. And if you're not looking for full-time office space but need a place to host a workshop or small meeting, we also offer conference room rentals, perfect for off-site meetings, trainings, and workshops. Schedule your private tour today and see the difference for yourself. Visit jkenba.com. That's www.jkenba.com to learn more and reserve your space before it's gone. At J. Kenba Executive Suites, we provide the professional space. You create the success.
Welcome to the Byja Radio Show. I'm your host, Dr. Byron Jasper, and we are recording live with special production by Becnel Media. All right, we are back in the saddle once again for the amazing, illustrious Byja Radio Show. And if we are talking about the Byja Radio Show, and I use the term we, that must mean I'm in the saddle with the wonderful, magnificent, not the first, but the second, but still one of the greatest Georges that I know, Mr. George Becnel, aka PatientZero. How you doing, brother?
Hey man, I'm doing well, brother. I appreciate the kudos, man, and shout out to my good frat brother George, who I got to hang out with a little bit this weekend, man.
Yeah,
But yeah, I'm doing well, bro.
it was Georgia Palooza, from what I could call it, if that's okay. So I think it was going pretty well to say you all had a great time, and it was a great time for everybody who was present.
Yeah, absolutely, man. It's always a blessing to sit down and fellowship and have a few libations. It's always a good time, man. Maybe we need a sitcom. Maybe we need to call it Georges and Byron or Byron and the Georges or something. I don't know. We'll
Yeah,
come up with something.
I think either of the names will work, and I think it would definitely be a highly rated show for all the comedy that comes along with it. So we
Yeah.
are uh, we are coming back for, if I'm good with my math, are we on episode 36 or 35? I'm always getting confused.
36.
36. So episode
36.
36. That's what I was thinking. I was like, I'm pretty sure we did 35 not too long ago. So, I'm getting old and getting elderly up in this age with this memory. So, but episode 36. So we are talking about a topic that recently had some movement. It's been in the news for a while, but probably caught a little more momentum. And it's about basically undervaluing primary care. Newsflash, right? Not saying anything people don't already know, potentially, if you're a longtime listener, but undervaluing primary care when it comes to basically billing and how billing happens. So, specifically, one of the things that happens when it comes to how doctors get paid is they are submitting bills to insurance usually to be reimbursed. And patients here, I'm sure you're not familiar. I'm sorry, I'm sure you are familiar with that because we've talked about it before. So most
Sure.
physicians are submitting billing to the insurance companies. And when they submit the billing to the insurance company, what happens at that point is there is some type of formula that gets put together that says how much should be reimbursed to the physician for the work they did. Well, in recent news, there has been a push to redo how this is being set up for primary care doctors. And that's why we're talking about it today. So, Patient Zero, if you don't mind giving the people a little bit of information on things that will shape the topic of how the primary care space often has an undervalued approach when it comes to thinking and how people are billing and reimbursed within the space. So, any details you can share with people when it comes to just some primary care information, because we're going to talk about statistics and data. So, we always want to set it up using those things. So, what are your thoughts?
Sure. So, number one, I'm looking at some stats. In 2023, U.S. healthcare spending reached about $4.9 trillion,
Hmm.
and that's about 14, not 14, excuse me, 17.6% of our gross domestic product. So on average, that's about $14,000 a person on average, right? Um, and I seriously doubt if a lot of that is going to primary care.
Hmm. Yep.
If I had to bet, I bet that's more. So it's two things, just in my opinion, just in the mind of patient zero. Um, Number one, I think what happens is just Americans in general, we don't really lead healthy lives,
Hmm.
and that way, our health care or pursuit of health care becomes more reactive than proactive. So instead of just seeing your primary care physician, uh, getting annual physicals, things of that nature, we're like, okay, I feel good, so everything must be good.
Hmm.
And then sometimes it's not good. Then when sometimes when you delay care like that, you go to the doctor, all of a sudden you run up a big bill because number one, it's a few things wrong with you, not just one.
Hmm.
And number two, it could have reached um, a catastrophic amount or line, right? And it gets expensive. So I just don't. I said all that to say I just don't think people put a lot of value in preventative care.
Yeah. So I think the point that stood out to me with the stats we pulled was that there is a lot of spending that's happening in healthcare. Nobody's ever surprised when we say that spending is going in the higher and higher direction each year when it comes to healthcare spending within the state, the country. And different states obviously spend more, but overall, most states have more spending every single year. It's never like, oh, this state spent less. And then the last thing, as you already alluded to, is that usually primary care is going to get the least amount of spending, even though it's still going up. So if we're spending $4.9 trillion dollars in 2023, and this is the most recent stats that we could pull, that should say if we're spending that much money, why is it that we are potentially spending that much every year and it's going up, but people aren't getting healthier? Well, it's usually because we're having a rise in spending, but it's being pushed towards things other than primary care. So, what are we actually spending money on when it comes to different things? So, Patient Zero, we pulled some stats from potentially a few years ago. And if you don't mind kind of sharing when it comes to insurance and different plans, what the type of spending is when it comes toward primary care.
Sure. Um, so so about 4.4% of medical plus prescription spending went to primary care in 2022. So not even 5%. And it was down from 5% in 2018. So, you know, it's very, very low and it's abysmal. And question for you, Doc,
Mhm.
when you talk about primary care, that's not including urgent cares, right?
Right. So primary care for the purposes of the reports and things that we pulled were things like family medicine physicians, internal medicine physicians, pediatrics, and sometimes you can throw in there gynecological care. Sometimes you also throw in there psychiatry. So that's usually your three to four, with psychiatry possibly being a fifth, but family medicine, internal medicine, pediatrics, gynecology, obstetrics, of course, could be a little more specialized, but gynecology for sure, and then psychiatry. So that's usually your primary care definition. And specifically, when it comes to the types of spending, in 2022, there was an employer sponsored insurance, which is most insurances across the country, with the exception of Medicare. And only 4.39% of the spending went to primary care, which was down from 4.93 in 2018, which Patient Zero is referencing. So when it came to primary care spending in 2023, I'm sorry, 2022, we spent less towards that, even though, again, people are getting sicker and we're having more spending. And then when it comes to Medicare, which is basically the biggest payer probably across the country, and it's usually with elderly people, you're going to have even lower amounts at 3.86%. So you're going from 4.93 in 2018 for employer sponsored insurance. And then in 2022, 4 years later, it went down to 4.39%. And then in that same year in 2022, Medicare only spent 3.86% towards primary care. So that literally should tell you, even on the bigger insurance plan levels, that we're still not spending a lot towards primary care. And if we're not spending a lot towards primary care, where is it going? Well, it's usually going to specialists and specialty care. And the specialty care incentivizes people to potentially see specialists or to go into specialties in order to basically have a higher reimbursement or potentially get stuff done. And we'll talk more about what all this means in terms of the trickle down effect. But if more dollars are not allocated towards primary care, you're going to see more issues that come. And those issues are going to be something we discuss in a moment. But I want to see your thoughts on that. If you're saying, okay, Medicare, the federal government, when it comes to insurance, is only spending 3.86%, then employers are only spending about 4.4%. What are your thoughts on that?
Well, I just think people aren't prioritizing being healthy. That's my biggest thing. Kind of like what I said earlier. I think people are being more reactive, and they're not being proactive about their care. And when you delay care, because people, life be life, right? Let's keep it a buck. Life be life, and you put off what you can put off.
Hmm.
So if you're feeling fine, the doctor's not on your, on the front of your mind. You tend to, once things start happening, then it becomes a little urgent.
Yeah.
And a lot of times, we've discussed this in the past a lot. When things aren't prevented, they cost more, and I think that's a direct result of this. So you're going to see a lot of people just not taking care of themselves,
Hmm.
and then once something happens, it's going to be very, very expensive. So I think, in my opinion, you're a lot more qualified than me to speak on this, but in my opinion, I think the main point is we have to be more proactive about our health and get into primary care.
Yeah. Yeah. And I think overall, the framing of why we kind of chose this topic was in recent months. So last month, specifically August of 2025, when we were recording this, there were several major policy outlets that basically published reports saying how Medicare is undervaluing primary care. And based on that, it kind of intrigued me to say, okay, well, what does that mean? What is that going into? So we started pulling statistics since the report framed it that this was not being prioritized. And that's when we saw that Medicare is spending in 2022 less than 4% on primary care. And employer sponsored insurance is spending about 4.4% in primary care. So that alone, that report kind of says something that has been going on for a while. And you can imagine if it was like that in 2022, which is the most recent statistics we could pull, what was it in 23, 24, and more than likely 2025? So at the same time, these reports came out saying how Medicare undervalues primary care. We went into a little more depth to say, well, what do they mean by undervaluing, not only from a standpoint of just not having a lot of spending going towards it, it was more so the reimbursement where people in primary care are not getting their higher rates of reimbursement for what we have been told is something called cognitive work. Now, George, that phrasing sounds pretty simple. I think most people understand
Mhm.
what cognitive is and what work is. When you put them together, cognitive work probably seems pretty simple. But what does it come to you when you hear Medicare doesn't prioritize cognitive work? And this is just me asking you your gut reaction. What does that mean to you if you hear somebody say, well, Medicare doesn't prioritize cognitive work towards primary care? What does that mean to you?
I think they don't prioritize doctors' recommendations. That's what I hear. If because you and I have had these conversations as a patient, right? I can speak on it since it's my health, right? But you and I have conversations about different medications or different methods of care,
Mhm.
and a lot of the challenges are getting insurance to pay for it.
Yeah.
And the fact that you went through law school, the fact that you went through med, you're done with school now, doc. But the fact that you went through med school, did your residency, did all these things to become a medical doctor is wild. That you know what you recommend as the best method of care might get turned down because of cost.
Mm-hmm.
You know what I
Yeah.
mean? And I think that's something when I hear ignoring cognitive work, I feel like when you come up with a diagnosis, you come up with a prognosis, and sometimes, the insurance company is a barrier,
Mm-hmm.
or the government, right?
Yeah.
So I think when they say they don't prioritize cognitive work, I think it's just that they don't trust your recommendation or prioritize what you think is the best route if it's not cost effective.
Yeah, and I'll go a little bit further because I think some of what you're saying is spot on. I think some of it is a little bit off, and I'll clarify. So
Sure.
defining cognitive work was something that came up to me when I heard they're undervaluing primary care, which to me it sounds like something that is simple as water is always wet, right? Like it's almost like kind of you already know that to be true. But what specifically are they undervaluing? So it said cognitive work. So what they're calling cognitive work is basically when a primary care physician is evaluating a patient, coming up with medical decision making, coming up with management of chronic illnesses, trying to decipher what is going to be the best medication, what labs to order, how to evaluate those labs, how to counsel the patient on what the labs are. All of that is considered being cognitive work. So what they're saying in so many words with the reports is that they're undervaluing that type of work and instead prioritizing or having a preference for things that are not deemed to be cognitive, right? So it's not saying other types of work are not as important. It's saying that, well, look, we think that your work is important, but if we're going to pay people, we're going to pay them for the things that aren't necessarily preventative. We're not going to pay you as much as we would pay somebody who's doing a surgery because when you're on the phone talking to them about lab work, that's not as time intense or cognitively um, difficult, right? So based on that, that was the whole concept of, well, what is cognitive work? Well, if you're evaluating the patient, you're making decisions from a medical decision standpoint, you're trying to figure out prescriptions, you're doing labs, you're doing all this stuff. Yeah, that's important, but it's not as important as doing a surgery. And you will hear some people say, well, look, we agree. The surgeon should get paid more because surgery is more complex. And you won't hear me argue that. I'm never going to sit here and act like I can go and do surgery because, oh, yeah, it's the same thing. But my thought is if we are prioritizing that surgery should be more pricey and get higher reimbursement, what do you think people are going to get steered towards when it comes to choosing a profession? What do you think people are going to get steered towards when it comes to what is going to get covered? Well, hey, we're going to try to make sure you have more surgery because that's what's going to get more reimbursement. So that's what we're going to steer towards compared to, well, we get paid the same whether you do blood pressure management and working out and eating better. So we're going to prioritize that just like we do surgery. Like they're not even. It's so starkly different that your specialists and your procedures are getting so much more favorable valuations, and prevention is getting so low on the valuation scale. It just turns into, well, why don't we do more of that and less of this? And I think that's what it shows up when it comes to those things, because things inside the exam room, reviewing charts, returning messages, having phone calls, don't really equate to, well, we're going to see more specialists. And that's how it kind of breaks down. And that's what the whole cognitive work part came to be. It wasn't necessarily just, hey, we don't trust your medical decision making. It's more so, we know you're doing it. We just don't think it's that important. That's kind of what it came across to me. And maybe that's just
So
me, but that's what it sounds like.
and just listening to what you're saying from a medical professional standpoint, I'm listening to it as a patient, right?
Hmm.
So there's a couple of things that I'm hearing that's like very scary,
Hmm.
right? For one, when you talk about prioritizing surgeries, um, and you talk about the doctors that are steered into the more money making um, parts of medicine,
Hmm.
I feel like it almost sounds to me, and I don't believe this to be true because you've been a general practitioner as long as I known you, right?
Hmm.
But it sounds like your first, your top of the class, your smartest students, your more skilled doctors that just go to surgery, and
Hmm.
then what's left is going to be primary care.
Yeah.
That sounds like what you said. Number one,
That is
which
100%, and you are astute in your basic breakdown of that. That's basically how medical school works, and that's unfortunate, right? Like, rarely do you have the, for lack of a better term, smartest people in the class choosing primary care. It does happen, but usually they're going to surgical specialties because that's what it's deemed to be the best of the best. Because in order for you to be a surgeon, you have to have X, Y, and Z. So the criteria, oftentimes, to get into the specialist category, specialty services, and all of that, are a lot more strenuous. And people tend to look at primary care as the basically bottom of the barrel or the easiest to get into. And it's unfortunate because I think that also incentivizes people to literally look at, hey, why are we going into that field? Well, it's going to probably be looked at to be more prestigious, and it's also going to have a higher return on payment. And we are able to prioritize this in healthcare in America. So this is why you want to go into that.
so that's problematic. Number one.
Hmm.
Now, granted, if you join the Byja clinic, you won't have that issue, right? But that's what it sounds like is a as a general
Hmm.
American issue, right?
Yeah,
And number two, the second thing I heard is because I know doctors get reimbursed for particular services.
correct.
So the
And we
dangerous part,
and we have an example of that. So good cue up. Go ahead, but go ahead. You were saying dangerous part.
but but the dangerous part about that is now if I'm seeing a specialist and there's a recommendation, being I'm in sales, I always want you to get the higher package.
Hmm.
So, or is the doctor going to advise that I do surgery
Hmm.
because that's the more reimbursable or the more profitable thing to do, or does he know that I can be fixed with a shot or some physical therapy, and we go that route? That might not pay him as much, but it might be just as effective without, you know, put me under the needle or under the knife, right? So those are the two things as a patient that's very concerning to me, and I think should be very concerning to everybody listening.
Yeah, and I think you're spot on because that is a huge thing that a lot of people think, right? Like they're recommending surgery, and it's because they just want to cut on me, and it's oftentimes now a barrier to treatment, even though the surgery might be something you need. It's because you're now thinking that they're incentivizing you to have surgery because they're going to get paid more, and it's hard
Correct.
to argue that point because I mean, what do the numbers tell us? You do get paid more, right? You can't argue something that's factual unless you just like arguing. And it's true that people who are in specialties tend to get paid more when they do procedures. And rather than me telling you not to have a procedure, I'm probably going to throw the procedure in there with other things because it's almost like, hey, we can do both things and the reimbursement is going to be higher than just focus on the slow and steady approach. So being specific to kind of highlight what we're talking about. So, George, have you ever heard of something called the resource-based relative value scale? The resource-based relative value scale. Have you ever heard of that before?
I've seen it in the notes.
Okay,
I
so
have not heard of it.
you've not heard of it. It was in the notes. So I'm glad that you looked at the notes, my friend. So the resource-based relative value scale is something that basically comes up and assigns values that heavily favor procedural work. But I went into a deep dive on what this is, right? So I'm going to give a little bit of background. So if you don't mind, I have a little bit more detail on this whole setup, okay? So specifically when it comes to the resource-based relative value scale, it's the payment system that Medicare and many private insurers use to determine how much healthcare providers are reimbursed for medical services. So in so many words, Medicare set this up to say this is how much you're going to get paid for the work you do. That's the simple version. The thing that most doctors which again, before I looked into this episode, I didn't know what that was. We hear something else called RVUs, which are the relative value units. RVUs are kind of the thing that basically says how much you're going to get reimbursed within the within the resource-based relative value scale. So the system as a whole is the resource-based relative value scale, and we physicians, nurse practitioners, physician assistants can earn RVUs. And RVUs are basically a formula that when you add it up and multiply and divide all that, it gives you your payment. Does that make sense so far?
It sounds unnecessarily complicated,
Of course it does, right? I
but
mean, what do you think
but
this is?
it
Medicine? Like,
no. Well, what I said, no, I value things that are complicated that are necessarily complicated. I think this is unnecessarily complicated.
I agree with you
Just me
100%.
personally.
I agree. The fact that I have to literally keep reading it over and over to actually pronounce it, what is it, resource-based relative value scale, like that alone right there tells you how complex we're about to get. Then
So
there's a relative value unit inside the resource-based like it really just turns into foolishness, right?
bro, how do you base this like off anything? Like, like I don't think.
It gets more complex, my friend. If
But
you thought we were already complex, I'm ready to knock your socks off, sir.
so like for example, like a colonoscopy in Baton Rouge is gonna cost the same thing as a colonoscopy in San Francisco. Like
Because that would make sense, right? Hold on. Now this gets better. So in the relative value unit, the RVU, within the resource-based relative value scale, there are, mind you, 4 to 5 things that you have to put together to get your payment. Okay, I'm gonna say that one more time. The RVUs are calculated based on 4 to 5 things. The work RVU, the work RVU is one part. The practice expense RVU is the second part. There's a malpractice RVU, which is the third part. There is a conversion factor, which is the part you just said, California versus Baton Rouge. That's the fourth part. And I'm sorry, I did that backwards. The geographic adjustment is the California versus Baton Rouge. That's 4. And then the conversion factor is 5. So that's the 5 parts to determine how you get paid. Your face says all I needed to say, right? The disgust in your face tells me all I needed to say. The physician work RVU, the malpractice RVU, the practice expense RVU, a conversion factor, and a geographic adjustment. Those 5 things determine how we get paid. If we're doing insurance reimbursement within the whole Medicare resource-based relative value scale. And with that being said, we literally said, okay, well, let's figure out an example of how people are reimbursed. So I threw some things together to just get a breakdown on this. And I said, I'm gonna look at 3 different types of RVUs. One for primary care, one for hospital care, and then one for a surgeon doing a procedure. Okay? So for a primary care office visit that is billed somewhere between 30 to 39 minutes, a half an hour to um, almost a full hour, right? Depending on how you want to look at it.
first of
For
all, anybody that's billing a half an hour to a full hour, they're lying. They didn't see anybody
and
for a
again, I
half an
agree.
hour or a full
I
hour.
agree. So for 30 to 39 minutes or half hour plus, that's about 1.9 RVUs. 1.9. Okay, because clearly having whole numbers wouldn't make sense. And 1.9 RVUs, according to the conversion factor is something Medicare puts out every year. So that's what that is. I should have explained it earlier. Everybody understands geographic adjustment. I can explain the other 3, but I won't bore you. But with all of that, for a primary care visit, with the conversion factor that Medicare assigns and geographic adjustment, all that, it's 1.9 RVUs, which came out to about $62. Reimburse $62 for 30 minutes, which some people that obviously is a fair wage. No problem there. For a hospital visit, if you're going to the hospital and having a hospital visit, one hospital visit is 5.17 RVUs, which came out to about $167. The surgeon, the surgeon has something called a global period where they can basically do your pre-op, your surgery, and your post-op, and it's all billed together, right? So for that surgeon, it's 17.26 RVUs, which came out to roughly $558 in this example. Now, again, these aren't real numbers. These are examples. And it's only giving you basically the simplified version of this. Now it's more complex, but for an outpatient visit, it's about 1.9 RVUs. For a hospital visit, it's about 5. And then for a surgery, it's about 17. And in that example, you go from $60 to $167 to $558. So that goes to show that when you start to obviously extrapolate those things, the numbers are going to get completely outrageous. You're going to spend more time possibly doing a primary care visit at an hour and a half, and you're still going to make less than one hospital stay, one hospital visit, if you will, for one day. Because one hospital visit is 167. If you're doing 62 times 3, 180 or so, right? So at this point, you're about the same for for 1.5 hours of work than it is to have one hospital stay. And that's not including any extended hospital stuff, right? So I bring all that in a roundabout way to say that's just a random example. But to go one step further, I looked into it a little bit more. I say, well, how much is it when you're billing for an actual procedure? So one of the things I got for an example was that a primary care visit, again, depending on what you're billing, all the stuff you're doing, you may bill it at somewhere around $250. But for a colonoscopy, which you alluded to, it's about $1,092. And a colonoscopy, if you don't know, doesn't really take that long. You may not remember it because obviously they put you under sedation. So you may go in thinking it took a long time, but if it's not a really problematic colonoscopy, it may not take anywhere from 20 to 30 minutes. It could be sometimes shorter than that. It could be longer, of course, but if we're at around 30 minutes and your primary care visit took a long time, including all the labs and things that come along with it, all the medications that are prescribed, all the phone calls and the counseling and the prevention, you're still only getting a fraction of what a surgeon or a procedure focused specialty gets. And that's the part of the undervaluing, because it's not about the amount of time you spend with people. It's not about the attention to detail. It's about the idea that this is a procedure. The procedure should be more complex. And if it's more complex, at this point, we're going to assume that all of the procedures are more complex than the primary care side. So we're going to reimburse those people higher. And if we're reimbursing and incentivizing people to do more procedures, what do you think happens to the primary care side when it comes to the appeal for people to go into primary care? It's not something that's really, for the most part, attractive, right? A lot of people tend to say, you know what? No, I think I'm going to do something else because I can possibly go in and do a handful of surgeries in a day, 2 or 3 surgeries in a day, or I can go to clinic and see 50 people a day. And if I see 50 people versus 3 surgeries, I'm still making more on the 3 surgeries. And if you frame it like that, most people would say that's insane, but that's pretty much what it is. Because it doesn't make sense in any other industry that if you're having more work done from a volume standpoint, you tend to potentially make less. Doesn't really work like that. So PatientZero, I've been going on a little bit of a rant. So I wanted to know your thoughts, because it sounds like to me, it's a little backwards. Maybe that's just me, because I think trying to keep people healthy should be incentivized more, prioritized more, or valued more. But obviously I'm biased. So what are your thoughts?
I mean, I agree. You know, America is some of the most unhealthy people on earth, and because, for reasons like you just stated, not only do people put off things that they should, but we incentivize more complicated methods of medicine, right? So we're incentivizing surgeons and specialists and things of that nature instead of primary care, where, you know, if we do a good enough job in primary care, the need of the surgeons and the specialists go down, right? It just makes me sick, to be honest with you, because it's just another example of how Americans incentivize the wrong thing. We are incentivizing economics over being healthy.
Hmm.
And
Hmm.
look, again, bro, you know me. I'm a business major, MBA, love money, love making money. I love the study of economics. I love it. But at the same time, at some point, your conscience has to intervene on some of these decisions, right?
Right.
And I think incentivizing people to stay healthy is a whole lot better to incentivize fixing sick people,
Yeah.
right? Let's prevent people from getting sick from the beginning, and that way we can have a more healthy, more functional society, in my
Yeah.
opinion. So it's as you were speaking, I don't know if you can see the look on my face. It's pretty disgusting, in my opinion.
Hmm. Yeah. And I think overall there are two big parts that I'll drive home before we, go to our first break. The idea is that if you're in the surgical field or you're in the specialty field, again, the things you're going to probably get a higher reimbursement on are complex things, surgeries, procedures, injections, uh, you know, um, laceration repairs, all these things that you're going to potentially have to do a little bit more intense um, hand-eye coordination, stuff like that. It's going to probably end up giving you a higher return. And again, no argument here. But the inverse of that, or the opposite of that, is when you're kind of saying, well, look, for primary care, you're not doing any of that on a regular basis. So we're going to only basically give you the bare minimum. You're now telling a primary care person that in order for you to make more, you have to do more volume. And what do you think more volume means if we're not doing procedures and we're not getting reimbursed for those types of things? That means seeing more patients. So now it doesn't matter how much time I spend with someone and how complex they are and how many things I did to keep them out of the hospital. I'm just basically being told you get paid a flat rate based on this being all the same. And if it's all the same, we're now seeing 30 plus people a day on the primary care side, if you're lucky. Some people are seeing 40 plus, 50 plus, and even 60 plus a day. And I don't mean 60 plus for a week, I mean for one day. So now, if you're seeing 60 plus people in a day, how much time do you think you're really in the room with the patient, keeping them healthy, preventing them from having problems? You're not. So when
First
you're
of
not,
all, you're not giving people good care if you're seeing 60 people a day.
correct.
Hey, let's call it what it is, And look, I got all the respect in the world for doctors. You know, I didn't go to medical school.
Hmm.
I don't know if I would have a good bedside manner or patience for some of that. So I respect, the job that doctors do, but they are human, just like anybody else.
Yeah,
And at your job, you can't be on 62 projects and be effective.
there you go. There you
You know
go.
what I mean? You
Yeah,
just can't do it.
yeah,
So not only are you not getting time with the doctor, because we talked about the average visit 7 minutes, right? You talk to somebody 7 minutes, that's already, you know, lackluster in my opinion in terms of, helping somebody, right? But also, you're seeing 62 other people. Like mistakes can be made.
hmm,
What
agreed.
if you didn't get Mr. Johnson his medicine? Or what if you gave Mr. Johnson's Miss Smith's prescription,
Hmm.
and vice versa? Like it's just I wouldn't want to be a primary care physician either
Yeah,
if under those circumstances, just being honest.
yeah. And then also one step further, so we're incentivizing them to see more people, which you already said there's more likely to have more stuff getting missed or mistakes. What is the other side of that? Once again, it tells them that you don't value other stuff other than volume. So me calling you to give you your lab results is not prioritized and valued. So I'm not going to really want to do that. Me basically being on the phone with you to answer your questions, I'm not going to want to do that because I'm not getting reimbursed for that. Me responding to emails, me filling out paperwork, me trying to explain things to your family member because they're asking questions that you don't understand, I'm not getting paid for any of that. So I'm literally being told that I get paid on one thing and one thing only, volume. So now I'm incentivizing seeing more people, doing less of the non cognitive work, and the cognitive work that I am doing isn't reimbursed. So I'm not going to do that. And that just tells people that, hey, you do better going into other specialties. So based on that, we'll slowly close out by saying, how many, from a percentage standpoint, do you think, student wise, medical students specifically, chose primary care? 0 to 100%. So 100% chose primary care, and the numbers that we were able to pull for this were from 2022. So in 2022, how many people do you think chose to go into primary care?
So I'm gonna take a wild stab in the dark at this.
Hmm.
I'm going to say 24.4% chose primary care.
Okay, and where does that wild stab come from? I just want to know because you were in the dark, so I didn't know if that just kind of came to you and you felt it or what happened exactly.
So I had the Mamba mentality on that one, so I chose 24 for Kobe, and the point four was because I was thinking about how Brett Favre got in trouble with some money. So it's 24.4% is my guess, and I'm
Yep.
gonna lock it in.
Yep. So you are spot on. It is literally 24.4% in 2022 that chose primary care, which is the lowest rate in 10 years. So in 2022, out of all the med students across the country, less than 25% of them say we want to go into primary care. And again, of those people who chose primary care for whatever reason, that doesn't mean they all stayed in primary care. Because believe it or not, some doctors may go into primary care to start, and it's because of some reason they couldn't get into a surgical program or there weren't enough spots. And then the surgical program opens up a spot. That person who wanted to do surgery in the first place will possibly go into that surgical spot that's open because they're like, why would I want to stay here? So
Oh,
now that 24.4% could actually be 18%. And now we're again feeding this beast of just deprivation within primary care. And that's something a lot of
oh,
people don't think. They don't
question.
realize.
What about the person that's like, man, I want to be in primary care, I want to make a difference, and then they start seeing 62 patients a day, and it's like, man, the hell with this. Like, let me go do something else.
Yep, I
You
agree.
know, like
And the
that.
burnout that comes along with it, the stress that comes along with it, the amount of time that you're away from your family that comes, like all of that is relevant in this when you're undervaluing this quote unquote cognitive work. So, to hell with this is probably the nice way of saying it, right? It's probably
What's a
better to
family
say,
show?
yeah, it's probably better to say a lot of other words that may drive the point home. But we're not going to do that because, as Patient Zero pointed out, this is a family show. But we are going to go ahead and take a quick commercial break, and we'll be right back after this.
Hi, it's Patient Zero from the Byja Radio Show. Are you tired of the broken healthcare system? Frustrated by long waits, rushed visits, and sky high costs? Yeah, I was too. So if you're tired of dealing with any of those things, then I highly suggest you check out the book Byja Blueprint, an introductory guide to direct primary care written by our own Dr. Byron Jasper. It breaks down all you need to know about direct primary care, a model that makes healthcare simple, affordable, and personal again. The book covers topics like how DPC differs from traditional insurance based care, what's the difference between direct primary care and concierge medicine, how employers can use DPC to cut healthcare costs, how this model reduces burnout and improves work life balance for physicians, and so much more. Whether you're a patient like me, a doctor fed up with burnout, or a business owner tired of rising healthcare costs, this book lays it all out in plain English. If you're ready for something better, check out Byja Blueprint, available in paperback, audio, and ebook format. Visit bookstoread.com/Byja Blueprint DPC and get your copy today.
All right, coming back from commercial break, and we are jumping back into this topic about undervaluing the, for lack of a better term, thinking piece of primary care. And with us having that undervaluation, how it's basically leading to a trickle down effect of things within the primary care space and possibly the exodus from the primary care space. And patient zero, we were talking about numbers, and I think you came up with an amazing stat of 24.4% from some mythical place that you pulled out with a sports reference, which is pretty funny how you always bring it back to sports. But hey, it's a talent you have, so I appreciate you for that. But I want to give more stats because it just hopefully gives people an idea that we're not just saying stuff that is, coming out for shock value. We're saying this because these are numbers that are readily available, that are easy to vet, that we can
Sure.
potentially say, hey, this is where we are trying to drive the point home. So let's be specific. So anything you can share from a statistics data that people may not know when it comes to how this undervaluation of primary care is causing some type of effect on the people in primary care or the space of primary care as a whole.
Well, as you can imagine, I think it has the greater effect on like the inner cities.
Hmm.
When you look at ESI spending in 2022, um, rural areas, they spent is 4.56%,
Hmm.
and in the urban areas, it's 4.37%. Like a disparity, a slight disparity, but it's disparity nonetheless. But then when you look at Medicare spending in the rural area, is 6.67%, and in the urban area is 3.4%, almost half.
Hmm.
So that's kind of loud, right? So you're wondering what is the difference between the urban areas and the rural areas. You would assume that the urban areas got more access to different avenues, but I'm not sure.
Yeah. So I think to again drive that point home, so ESI is employer sponsored insurance and Medicare is of course Medicare. So in 2022, those were the numbers that George pulled out that within employer sponsored insurance in the rural areas is about 4.56% in terms of the spending towards primary care. Urban areas is 4.37%, and Medicare for the rural areas is 6.67%, 6.67%, and urban areas 3.4%. And again, that's just towards the uneven investment when it comes to spending within different types of settings for primary care, where surprisingly enough, if you're in a rural area, they probably have to spend more on primary care because there are not a lot of hospitals and surgeons and specialists in those areas. So they don't really have a choice. But if you do have a metropolis or a big booming city where a lot of people will reside, it tends to oversaturate with those specialists and less on primary care. So it's not surprising. And I'm pretty sure people kind of know that if they're in those big cities, when they go to try to get an appointment with a primary care doctor, and even specialists, there's long waits. But you would think that shouldn't be as long of a wait for primary care because it should be where we have more primary care doctors if we're on prevention and wanting to keep people healthy. But it doesn't actually work that way. So one more thing that I'll pivot to is just saying that from the overall numbers when it comes to primary care. It went from basically clinicians overall, we were at 105.7 per 100,000 primary care providers. And then that was in 2021. In 2022, it dropped to 103.8 per 100,000. So we are seeing a decline in primary care providers, which is not surprising. A lot of people know that. We actually talked about the shrinkage and the shortage of primary care in episode 9. So way back in season 1, we spent time talking about that. We also know that less primary care physicians are being produced from a medical school standpoint. So there's a decline in those that are already in primary care. There are less going into primary care. There are less in inner cities than in rural areas. There's more uh, focus on getting people into specialty fields, and specialist care has more reimbursement. It's just a bad recipe to say we really focus and want to focus on keeping people healthy. It doesn't really make sense to say we want you to get into primary care, but yet we do everything the opposite to get people into primary care. And the part that I always find very, very special, and I mean this in the most sarcastic way, is if you talk to the specialists who are getting reimbursed at higher rates, most of the time, if you start talking to them about a lot of things that are not within their specialty, the thing that they will utter quickly is you need to go see your primary care doctor. Like it always comes out that they tell you you need to get a primary care doctor because we don't do that. We don't feel your blood pressure medicine. We don't take care of your cholesterol. We don't do your diabetes. We're not going to talk about your foot pain if we're not a foot doctor. Yet that's who's getting the lion's share of the reimbursement. So if you're paying them more, why don't they cover more things? It's kind of backwards. If we're doing more for the whole person, from the head to the toe, from the mental health to the bladder health to the back pain to all of this, why wouldn't we have a more equitable breakdown in reimbursement when they're constantly telling you you need to go see primary care, even in the emergency room? If you've been in emergency room, patient 0, when you are done getting all of your emergent things taken care of, what do you usually hear them say? You need to go see your
Follow up
primary care.
with your primary care physician.
So why is it if everyone in the healthcare space utters that phrase, that no one says, yeah, let's go ahead and pay them more or give them higher reimbursement. Doesn't make sense. It's, as you said, I
Mhm.
think it's set up that it gives the facade that we are going to specialize in keeping you healthy and keeping you out the hospital and all that. But yet we really are just saying it. It's lip service. And I don't think that makes sense. So with all of that being said, Patient Zero, what do you think is being done about this? Do you think there's anything specific that is being done about it? Or do you think there's anything that should be done about it?
So there's nothing that's being done about it, and there will never be anything that's being done about it
So
because
so you're saying there's a chance.
yeah, there's a chance. There's a chance. There's a snowball's chance in hell. It's just I think my Saints have as much chance of winning the Super Bowl this year as somebody fixing this, right? So
I,
thing about it is,
I think they have a much better chance of winning the Super Bowl than somebody fixing
right? Facts, facts. No, you're not lying because here's the thing, you know, you have to understand the economics of everything, and everything in America comes back to economics,
hmm
never fails.
hmm
And I think it's crazy that we're having an economics discussion about when we're talking about healthcare.
hmm
I think that's kind of asinine in my opinion. Keeping people sick and treating sick people is profitable. I'll say that again. Keeping people sick and treating sick people is profitable. Preventing people from getting sick and curing diseases is not profitable.
hmm
It will never be fixed. Now, what should happen as a country, if you want more productive citizens, you want to keep some of your insurance costs down, keep people healthy,
Yeah.
incentivize the primary care physicians, incentivize like we got all kind of programs. Like if you go to school and you get a government job or something like that, they'll forgive your loans if you work like X amount of years and all this, that, and other. We should forgive loans for med school because I'm hearing there's a lot of them. There's it's a lot of loans
It's a lot.
when
It's a
you go
lot.
into med school.
It was it
You
was it
know,
was very inexpensive, sir.
for being primary care doctors in underserved communities or
Yeah.
being primary care doctors. Period.
hmm
You know, and you got to incentivize that so people can be healthy. You know what I mean? Because I think to set the expectation that to be productive, you have to see 60 people in an 8-hour workday, and then follow up with prescriptions and phone calls. That that's not attractive. That's not attractive to anybody.
hmm
So I think you should incentivize people that do come out of school and go work in primary care, give them some type of loan forgiveness or whatever, just something. And I think that'll kind of begin, you know, getting America healthy. But they won't do it.
Yeah. Yeah. And I will say to the rebuttal of what you were saying to an extent, they're always trying to do stuff. Now, whether it's going to work is a different conversation. And one of the things that I pulled up was just what are we trying to do to potentially fix this, right? Like there's all this data and all these statistics on why is primary care being reimbursed less? Why are specialists being reimbursed more? Why are things going down in terms of cost? Why are things going up in terms of cost, but down in terms of reimbursement? Why are doctors having to see more patients, but yet making less? Like I saw all this data. So I was like, well, are we doing anything to actually stop this, right? And there's all this stuff that is supposedly being done. And everything I've read, none of it gave me the sense of, oh yeah, that sounds like a great idea. That's going to actually happen. It's just same thing we talked about last episode. It's great in theory, but the execution is going to be very hard to do because it's so convoluted. We talked about RVUs earlier and how it actually is broken down from a payment standpoint. And it takes five things that are damn near impossible to understand. And that's how you get reimbursed And now by the reimbursement, it can be like it's all this stuff that just gets so confusing, only to find out that at the end of the day, it's just the same when it comes to the solution. So I'm gonna read a few of them off to you, and I just want to just go ahead and kind of give you a sense of what they're quote unquote doing. So in the I think it's the Centers for Medicare Services, the 2026 physician payment rule is something that they are trying to do, which is one of the reforms. It's supposed to cut spending waste, improve chronic care compensation, and adjust RVUs to better reflect time and complexity for basically what you're doing. Now, it's supposed to do those three things. Again, sounds great in theory, but how and what when you have to adjust RVU spending and reimbursement, and one RVU is this, and this is 2, and this is 17, and this is 12. Like, it's just, okay, sure. Yeah, that sounds simple enough. As you just said, it's unnecessarily complex. There's also something called advanced primary care management payments that are being started in 2025 to better support longitudinal care for high needs patients. So basically, they're trying to raise spending from Medicare from 5% to 8% when it comes to primary care, and doing that in this special payment way is supposed to be something they're trying. They're also looking at alternative payment models and things like team-based care and monthly payments and outcome-based bonuses. All the things that sound really familiar. You may have heard of some of those before, but all of that is another level. So there's the Medicare level, there's alternative payments, there's state level stuff, there's policy stuff, there's all these different things to solve the problem. And all of them that I read, none of them made sense to me, where I was like, oh, this is really easy to understand and really simple, that a lot of people are going to be able to do that, and it's going to be so much better. So I wanted to at least give you a few to see what your thoughts are.
So what is a high needs patient?
You said the same thing I said. I have no idea, but hey, it's no different than when we said ultra processed foods on the last episode, right? Like,
So
it could be so many things that, how do you even define that?
so have you ever like seen the tax code?
Yes, I have. Absolutely.
How isn't that like something that's pretty specific?
I think some of it is. There are very specific portions, but that's usually when there are loopholes and people close them. But a lot of times, in some areas, it's super broad. But yes, I think the intent is always there for it to be specific. And then there's always bad actors and whatnot that can find little ways to get around it. And I think this is the same thing, right? Like, a high needs patient could be deemed as somebody who needs to be seen 6 times in a month. But what does that have to do with a person who doesn't need to be seen 6 times in a month? They just need to have a phone call that's going to take time. And if you're on the phone and they're not reimbursed, they're not going to do that. So now you're bringing them back. Like, it's just kind of the same thing. It's like we're not fixing the problem. We're just throwing more stuff at it. But I'm
My
sorry,
my
I
point
probably
is,
hijacked it.
well, my point is this: we live in America, and and there's some foolishness going on in the country. I don't care to comment on it, but however, it's still the greatest country on earth,
Yep,
right?
I agree.
We have the biggest economy on earth. A lot of people from all over the world come to study at our universities and get their education and things of that nature. My point is this: if America wanted to get something right, they have the ability to get something right.
True, true.
This seems more like a smokescreen, in my opinion.
Hmm.
They're not trying to fix this, because if you fix this, what is the result?
Yeah, a lot of people
What's
gonna
the
lose money.
result?
A lot of people
A
gonna lose
lot of
money.
people go lose money, because a lot of people go be healthier, and then a lot of people go use money. You go see your primary care physician. I don't know, let's say twice a year. How many less people you think will be on GLP-1 medicine?
Hmm. Yep.
How much less people is going to be relying on insulin?
Hmm.
How much less people are going to have like heart issues, or whatever you know whatever? People are going to be a lot healthier, and big pharma or the medical industry is going to be a lot less profitable. So they're not going to fix this. I don't care, and I hate to be Mr. Pessimistic, right? But at the same time, it's like, you're not going to fix what's driving money. So
Hmm.
I don't want to hear any type of plan they got to incentivize primary care because it's not gonna work. It's just not gonna work, and it's not designed to work.
Yeah.
It's just, hey, let's make it seem like we're doing something because we know that's the right thing to do. However, big pharma's making some money.
Yeah. Yeah. And I must say that it's unfortunate because you have been a champion of direct primary care. I think I'm pretty vocal about direct primary care in a lot of circles, whether I'm at a lunch table, people will ask me what I do, and then when I tell them and start explaining the model, people are oftentimes really intrigued. And rarely do I hear people say, oh, that's not a good idea. That's not a good system. That's not a good thing you're doing. Everybody is on board. Where the rift comes is that people are so tethered to their insurance because in their mind, they're paying so much for it, they need to use it. Rather than saying, well, how can we use it less, save the money, and go to the primary care doctor more often, which allows us to stay out of trouble. They're thinking that because they have a big policy that is quote unquote super expensive and covers everything, they now somehow are more incentivized to use that rather than to just go to primary care. So I think, as you said, they're not fixing it. They've brainwashed people so much that they're so slow to adopt something that is so basic that it just turns into a rat race or a hamster wheel, right? People just keep going around in circles saying, I'm going to do it when, I'm going to do it if, I'm going to do it at this point. And 4 or 5 years go by, and before you know it, they're either sicker or something could have happened, and they're not getting any better.
So, newsflash: PatientZero has employer group benefits. I have health insurance. I use my health insurance, and I'm still a part of this model. Now, for me, and I can't speak for everybody, but for me, it was beneficial and advantageous to me to have health insurance and enroll in the Byja clinic with direct primary care. You know, the numbers worked out because I lowered my premium. I got a higher deductible because I don't use my insurance on the membership portion of it, but it all balances out, right? Because again, you know, let's call it a buck. You probably don't know what you're paying for anyway. When you're looking at your insurance, most people don't. Now, I'm gonna say there's gonna be some people who do, but most people don't,
Mm-hmm.
right? But to me, I don't mind paying my membership fee because I haven't been to urgent care in 5 years.
Mm-hmm.
You know what I mean? Because as part of the clinic, I got 24-hour text to chat or whatever you want to call it. I can get a prescription sent, and I don't have to worry about urgent care. Now, you know, I may have to have a hospital visit. You know, life happens, right? But I'll do urgent care. And when I did do urgent care, I would get bills in the mail for $250 here or $300 here because my insurance paid a portion of it, didn't pay the rest, or whatever have you. So what I'm just saying, like, have health insurance. Use your health insurance. You can use it on your prescription, use it on your labs, use it when you go see a specialist. But just because you have health insurance doesn't mean you need to use it all the time.
Mm-hmm.
You know, because the medical industry is the only thing that we want to use insurance for all the time.
All the
Man,
time.
I've owned a house for like 4 years, and I've never used my homeowner's insurance.
Mm-hmm.
I never used it.
Yeah.
Or like I paid truck insurance. I pay insurance on my truck. I've used it twice. So why do you have to use your medical insurance all the time? I'm just saying.
Yeah.
It just, you
It's backwards.
have insurance. Yeah,
It's
yeah.
backwards.
But it is backwards. But like, forget everything that you've ever learned and do some research.
Yeah. And I think if people can unplug from that idea that insurance is healthcare, and if I have insurance, I have to use it. If they literally can do that, I think they start to shift where this primary care topic shifts as well. And it's not just in the patient side, it's everybody. It's the employers, it's the people who are in government that are potentially writing policies and making decisions for Medicaid and Medicare, if they can unattach from the idea that if you have insurance, somehow you're healthier, and start to put more into the actual health of the person, prioritizing getting them into the clinic and having long conversations where needed, because the long conversations means that people are really and truthfully getting better care, and it's making them healthier, and we're incentivizing healthier behaviors and healthier discussions, and insurance is outside of that equation. It's like you said, the car insurance or the homeowner's insurance, it's there because we know if something catastrophic happens, we got it. But until then, you on your own, go ahead and fix that toilet, go ahead and rotate those tires, that's on you. But if something catastrophic happens, give us a call. In the meantime, we're here. But in the meantime as well, it's on you. If people can do that with healthcare, the spending goes down. When dollars are now sitting there that haven't been allocated and used on stuff like copays and premiums and x-rays and all this small stuff that doesn't need it, that pot is now sitting there. You can now reimburse the primary care physician more. They're now reimbursed higher. More people going to primary care. So now we have more doctors focusing on prevention. It all of a sudden starts to change. Now, is it going to be that simple? No. You and I both know that. But can it be that simple? It could, because it's not complex in the direct primary care side to just say, how much does it cost? Okay, I'm going to pay that, and you give me medical care? Yes. Oh, that's it? Yep. From there, it's not even anything more complex than that. But people have to be willing to stay out of the insurance pool that allows them to think because they have insurance, they have to use it, and therefore I'm going to get better health care and I'm going to be healthier.
So, what's wild to me, and this just came to me. So I'm a sneakerhead, right? Doc knows this about me. Doc is one too, right? So, there's for y'all who don't know, there's a couple of brands like StockX or what they call GOAT, right? And what these people do, they have become an authentication
Platform.
program or platform, better word, for sneakers. So if you want to buy a pair of sneakers and you want to ensure that they're real, you tend to go to StockX or GOAT, right? Well, what's going to happen is you're going to pay a fee to StockX or GOAT for an authenticated pair. The seller, because they don't manufacture any type of shoes, the seller who has the shoe is going to pay a fee to GOAT. And you know what? You're spending more money on this shoe that you just purchased than retail,
Mm-hmm.
because you're buying a pair of tennis shoes from somebody else. So somebody's providing the shoe. They're sending it to this authentication place
Third party.
that doesn't manufacture
Mm-hmm.
anything,
Yep.
which
And
sells it to the consumer. And the consumer is paying, in most cases, way more money than the retail value of the shoe,
mm-hmm.
plus fees to StockX and GOAT because they don't make any shoes. All they do is authenticate.
Mm-hmm.
So when you think about how wild the idea is of buying a pair of shoes and paying for the shoe and paying someone else to look at the shoe first, is a little wild to me, right?
Yeah. Yeah.
Same thing goes for insurance,
Mm-hmm.
health insurance. And I'm not saying health insurance is a bad thing. You something catastrophic happens to you, you go to the hospital, by all means, right?
Yeah.
But there's a situation, if I'm sick and I talk to Dr. Jasper, and Dr. Jasper has a way of making me better, why should me and Dr. Jasper have to go to StockX or GOAT to get a solution
Mm-hmm.
to make me feel better when he went to med school, he did residency, he passed all the certifications and whatever it is over there, he did it, right?
Mm-hmm.
Because I don't know.
Yeah.
But it seems asinine to me that I have to go through somebody else to get some care, somebody who's like a business major versus the man who practiced medicine and who's certified in to practice medicine.
Yeah,
That's just my whole spiel,
yeah,
So I just find that to be kind of wild.
yeah. And I think at the end of the day, we all know that to be true. We all know it to make sense. We all know it to be factual. We just have to understand that if this is what we believe and understand to be true and factual, we need to start putting our money where our fill in the blank is, right? And I say that because if we're putting the money where the care is, for this phrasing or analogy, you're putting your money into the clinic and the physician and the office, not into a third party's hands. And a third party then pays the clinician or the clinic or the physician for you. Then you're kind of confused at what is being reimbursed and what really is being billed and how much did it really cost. You get a bill 6 months later because you thought it was paid, only to find out it was only 20% paid, but not 80%. And it's this much because the doctor billed this number and this number cost this. And it's all this confusion. And the two people who are potentially at the most risk within this transaction are the ones that have the least authority. So if that's the case, we need to reinvent the wheel. In this case, it's actually necessary. So we're going to slowly close out with that. So PatientZero, any thoughts, any things you want to give to the people for them to kind of take home with them after today's episode? I think we got two good episodes in the chamber so far. We talked about HSAs and how legislation is now pushing HSAs and DPC in a more prominent fashion. So I think that's huge. And now we're talking about how the potential incentive towards primary care is lower. So hopefully the first thing can help the second thing. But I want to know, is there anything you're thinking people should know after today's episode?
So in my opinion, just take charge of your health, you know. And I'm gonna say this every show. I'm gonna say it every time. Take charge of your health. The insurance company is not in charge of me being healthy. They aren't. Dr. Jasper is not in charge of me being healthy. He's not. He's a resource. The insurance company is a resource. They should be a minority partner in your health organization. They are not the main decision maker. You are.
Hmm.
So take charge of your health, do the homework, crunch the numbers, and do what's best for you and your family. Because some people may not be a fit for DPC,
Hmm.
but I promise you a whole lot more people are a fit than who are enrolled in DPC. I'll tell you that.
Hmm.
And once you make the decision to take charge of your health, you'll never regret that decision. So I'm gonna live till 117 years old. Dr. Jasper's gonna help me get that done. And I'm taking charge of me and my health. And I make my decisions, not doc, not the insurance company.
Yeah.
So do your work.
And I think the other part to emphasize is with him living to 117, he's going to actually be happy. He's not going to be the old, disgruntled man at all times. Now, when people are on his lawn, he's going to be old and disgruntled. But
Oh,
otherwise,
I'm I'm gonna be the old man in the chapter meetings talking crazy to the young people. Wonder why they doing stuff like this.
you know a few people like
Back in
that.
my day,
You know a few people like that already. I'm sure you already got a few in mind.
I'm gonna be worse. I'm gonna be like, boy, back in my day, we threw mixers with the AKAs and had fun. And I don't know what y'all doing.
And then they gonna say, back in my day, I'm sorry, they gonna say, and back in your day, you used to be in the waiting room for an hour and a half to see the doctor, and they was only in the room 5 minutes.
Yeah, yeah, yeah. Nah, man, I didn't. Homie, don't play that. I, I'm I'm straight hour. Dr. Jasper asked me questions I ain't come there to talk about. I go there, my leg hurt. Dr. Jasper go through my leg. He talking about my labs that I had a couple months ago. He asking me about my mental health. I'm like, Doc, I'm not emotionally ready to have this conversation. Doc is like, look, your mental health is important. We need to talk about this. You know what I'm saying? So like, man, I'm spoiled, bro. Like I can't go back to them 7 minute visits. You ask the doctor 2 questions, you got a list of 10. You only getting 2 out. And he like, well, I'm about to send a nurse in. And I'm like, bro, I'm not finished. Like,
I'm just getting warmed up.
right. Like, dude, I'm sick. Hell, it was hard enough to get this appointment.
Correct.
I done built up some stuff. I made this appointment like 2 months ago because I had runny nose. Now my shoulder hurt. Help me.
Now I got three more things for you, and they're like, nope, nope, nope. You only get one. Yeah, so that's unfortunate. Well, I'm gonna say this, and then we're gonna close out. So my thing from today's episode is that the numbers that we are talking about may seem completely egregious and out of pocket, but they're real, and we all know this to be true. And if I'm not mistaken, if you are potentially within the care of someone who is in primary care, you can always ask them about some of these numbers, and you can also ask them if they had to do it all over again, would they go into it and do it again? And I'm pretty sure most people would say they would go into the medicine side of it, but for the business side, they would like to do something else. And if they could start over and think of a way to just do patient care and deal less with insurance, they would do that in a heartbeat. And if that's the case, we're going to continue to incentivize people to consider direct primary care, both from the physician side and the patient side, because ultimately, if we can come together on that, where more physicians and patients are dealing directly with each other, they'll get better. And these numbers should highlight how much this is necessary, how long overdue it is, and how great of an impact it can be if we can get it right. So with that, please consider looking into direct primary care if you're not already doing it. If you are in direct primary care and other people are around you who don't know about it, talk to them about it. Trust me, you can do them a huge service by giving them that information and explaining to them that this model works, it is viable, and it can really change your life, your family's life, your business life if you're an employer, as opposed to just doing the same old broken system that's not getting anybody better. And if you do it and do it right, it is going to turn into something that is monumental and revolutionary, in my opinion. With that, Patient Zero, we're going to close out this episode. I think we went pretty long today. So with that, where can the people find you, my friend?
Well, they can find me on Instagram at Becnel Media. You can find me on X. I hate calling it X. Elon Musk, if you're listening, bro, you're not my bro, but I just say bro. Um, can we change it back to Twitter, man? I like Twitter. But anyways, Twitter at George_Becnel. And LinkedIn, I'm George Becnel II. If you have any questions about, how a patient is or how my experience is in direct primary care or how I crunch the numbers or anything like that, I'll be glad to assist.
All right. So for us on the Byja side, you can see us at Byja Clinic on our website, www.byja.org. You can also look at donating to our nonprofit and helping the less fortunate get into direct primary care by doing a donation to our nonprofit. Our website to do that is www.byjaca.org. We are also on Facebook, on Instagram, and on LinkedIn as Byja Clinic. And all that, I also want to add in that we are, of course, the author of Byja Blueprint, which explains how direct primary care works inside the space for patients, physicians, and businesses alike. And finally, we are extremely, extremely excited to say if you have listened this far, you are a real one and a true fan. So we are excited to have you on this journey with us, and happy to say that we are becoming a source of trusted media for a lot of people, Patient Zero. So with that, I think we are right to say we would want you to like, subscribe, share, follow, comment, do all the things that help us continue to grow this message and do a good job of reaching out to people and getting them to kind of get over the hump when it comes to their medical care so we can impact change and keep people around who we love and enjoy for long periods of time. So with that, we're going to close out episode 36 of Byja Radio Show. We look forward to seeing you at the next one.